let's switch gears a little bit, and I'm going to move on to you, Dr. Fleece. Could you share with us what motivated your organization to invest in this new software, and what made you actually select EndoTool versus other products that are out there?
Sure. So again, back in around 2019, our chief medical officers and our quality people were realizing that we probably weren't doing as well in our ICUs with glycemia control as we could be, and started wondering if we should do something. And I still remember this. The nursing director for the medical ICU said, "Hey, when are we going to implement that Epic module, EndoTool?" And I'm like, "I don't know of any Epic module called EndoTool. Let me figure this out." And honestly, started with Google and came across EndoTool and saw what it was, but then also realized pretty quickly there were other products out there. And so went to Medline and PubMed, like Medline. I'm dating myself, went to PubMed and went to Dexicus and found out there were some other products out there and was able to find, I think, this article that you have on the slide, which actually is the only article I could find at the time, that actually looked at outcomes between the products that were in the market at that time. And EndoTool was outperforming its competitors, by a factor of 10 or more, as you can see on the slide, on these bar graphs. So at that point, why would I choose to use a product that was, not nearly as good? So I started talking to the company, presented it to the health system CEO, who immediately endorsed it, because he actually has the wisdom to realize you can do a lot of cardiac surgery and whatnot, that the better we would manage these patients in the post-op period, the better our outcomes are going to be with infections and all that. So really didn't have to make much of a case, because leadership was already looking for some kind of solution to improve it. So we implemented it at the end of 2019 in our ICUs and our ORs, and again, have had good success in our patient population. I don't think we have the depth and breadth of usage that Tracy and maybe Joe have working at their places, but we've certainly been pleased with the IV product, and so decided really a couple of years ago, probably 2 years ago, we wanted to implement the sub-Q product as well. And we finally got to the point of starting our EndoTool sub-Q implementation with one of our community hospitals at the end of June. We are planning to roll it out to the mothership in late January, which is where the brunt of our residents and fellows and surgeries are happening. And then we have a few other hospitals in the health system that will then follow suit.
You're in the process of rolling out the sub-Q across your system. What have your learnings been with that?
Well, we did a lot. So the sub-Q is, both IV and sub-Q, it's really the work of using these platforms is on nursing. They're the ones checking the sugars, they're the ones getting the recommendations, tweaking the doses. So we really knew that for sub-Q, we had to do a lot of preparation with our nursing staff. We had to start sending up meal trays with carbohydrate counts on them, or at least total carbs, and so, because that's one of the inputs for sub-Q. And of course, then we had to have our nursing staff start to assess carbohydrates. Now, it's not fine, perfectly accurate carb counting of everything the patient takes in, but they had to start estimating generally 50% of the tray, 25% of the tray, things like that. So that was we had a lot of preparation on that, which of course then gets you to your orchestration of checking sugars, delivering trays, giving insulin around the meal times. So a lot of work on that. And then went live with the dosing algorithm itself. And as you can see from this table, so if you look at the greenish column, those are our pre-EndoTool sub-Q hypoglycemia rates. Then you see in the next one to the right, our EndoTool sub-Q for July through September. And you see the pretty significant decline in those rates of hypoglycemia. And yet we still have about a quarter of our patients on sub-Q insulin who are not on the EndoTool algorithm. And you can see here how the EndoTool algorithm is doing a better job at avoiding hypoglycemia than the sliding scale patients. But what I will note is that even the sliding scale patients, July onward, you see their numbers are better than they had been, in the green run-up period. And I think that's a reflection of all the nursing education and nursing preparation and operational preparation that you need to have it order before you, because just changing your dosing algorithm is only one piece of this picture. I think we also learned it was a big lift. It was a big change management lift. It was a big education lift, not just for nursing, but for providers. EndoTool can be a little more aggressive than what they're used to in a good way, in the sense of getting these hyperglycemic patients down into their target range faster. But that initially can worry on the part of nursing. Nursing calls the doctors. Should I really give this much insulin? The doctors who aren't used to it yet may be a little bit hesitant. So I think I would emphasize for those contemplating going to improve their sub-Q glycemic management that you have to take a look at your processes, and then you need to educate and build confidence, and then you will then see the full benefits that the EndoTool algorithm can deliver.
So for the others on the panel, you're not using EndoTool SubQ at your institutions currently. Have you thought about moving forward with that implementation at your institution? And what do you think is essential for a successful implementation? I'll start with you, Joe. Any thoughts on that? Because I know we've discussed possibly an implementation at your facility in the near future.
Well, I'll start by maybe stating the obvious that each hospital has its different needs. So there's clearly, almost to what Tracy was talking about, we have a lot of community hospitals. We have hospitals out of the region that there's no endocrine coverage. And so for our main hospital, yes, we'd like to bring it in. But I think we want to start with the places that have a bigger need. What the system is planning to do is try to get us to do virtual management in those hospitals with our glucose management team. So I think big picture, I don't want to grow the glucose management team to be an algorithm that's already there. In other words, having a person that I'd rather teach, again, as was mentioned, the nurses learn from this, the staff learn from this, the residents, but it's the nurse at the bedside that's then, with the backup of a very good algorithm, can then dose this very safely once, whether it's the hospitalist or whoever's the admitting provider says use EndoTool SubQ. So our plans are to start with a couple of the they just happen to all be more rural, but a few of the outlying hospitals, that would be a place to start. Because then my glucose management team wouldn't have anything to do. So I have to have, because that's largely what they're doing. So I have to have a plan to sort of decrease their presence there and build up the sub-Q there, make sure it's in the system working well with our EMR, and then expand it.
Interesting. Tracy, Dorothy, any thoughts about subcutaneous implementation with EndoTool at your sites?
So for us, it's we've become one under a system. So we would love to go to the SubQ platform, but we're within Trinity Health now, and it's 100 and something odd hospitals, and all decisions now have to go up to corporate kind of and back. So not for the lack of trying, it's just where a lot of decisions are made outside of local control anymore.
Yeah, that goes the way of big health systems for sure.
I don't hear it.
Dorothy, anything to add before we move on?
I am of the inpatient variety. So we do inpatient and outpatient. So we're the ones that do all of that. We are working on training the nurses because there is as I'm sure everyone also experiences, a staffing issue. And with staffing issues comes knowledge gaps. And so trying to retain staff, trying to train staff, trying to train those nurses, that's something that we're actually working on. So as of right now, within the main hospital, we are not having that conversation. We probably will have those conversations later at the new hospital that they're opening down the street, because that's going to be remote versus us physically being there. So there'll be kind of conversations.